Well, hey, everybody. Thanks for joining us today. This is episode 9 of the Cutting Edge podcast. Excited to talk cancer surgery today and the frontiers of what's going on with various types of treatments, things of that nature. We have a great panel of folks with us today. My name is CJ Brock. I'm the CEO of TexAssist Surgical Assist Staffing. Joining us today are my co-host Tyler Talman and Dr. Jeffrey Gahan, who is a surgeon. I don't know, do I call you a urologic surgeon? What is the technical title for you?
I think we can go by multiple things. You could say urologic surgeon, you could say urologist, you could say robotic surgeon. I think any of those things work.
There you go. So before we get started, what we're going to be talking about is the advancements in treatment in urology, and in particular in surgery. So before we get started, we're going to just make a mention to a few of the folks that help support us. So TexAssist, Carrington Advisors, Ortho Lone Star, Jen Eaton with Moonshot Marketing Group, really a tremendous group of folks that are supporting us in one way or another. We want to give them a shout out. Certainly want to give a special shout out to Jen Eaton, who's helping us manage social media channels. You can find us on LinkedIn. You can find us on Facebook. You can find us on Instagram. You can find us on YouTube. All the above, man. Connect with us every way you can because we deliver content all different ways. So with that behind us, we want to jump right in. So Dr. Gahan, again, thanks for joining us today. We know you've had a busy day in the operating room down at the VA, which we're going to talk about that a little bit too, because by definition, you are actually affiliated with UT Southwestern, but you're operating at the VA.
Both actually, yeah.
If you could help our audience understand a little bit about you, your background, where did you grow up, how did you decide to enter into medicine, and then what's been your path to where you are today?
Currently, I'm an associate professor at UT Southwestern, so I have a dual role at UT Southwestern and the VA. So I operate at both places, see patients at both places. Was born in San Diego to a Navy family, so moved all over. Eventually landed in McKinney High School, which is just up the road from here, and then went off to undergrad, and then somehow came back to med school down in Houston. But I did a brief stint of chemical engineering before I actually became a doctor. So
really?
kind of found the calling a little late. And then once I went to medical school, I actually kind of what sold me on urology was just seeing the robotic surgeries being performed down at Baylor College of Medicine in Houston. I thought this is just way too cool to pass up, and went to residency, which is kind of the training after medical school. For surgeons, it's usually somewhere around 5-6 years. And then chose to do a fellowship specifically in minimally invasive surgery. And as a component of that, I did a lot of my work in robotic surgery at that point. And then they asked me to stay on and build a robotics program at the Dallas VA, which I'm doing today.
Awesome. So you mentioned that you're part of a Navy family. So did you have any pressure from parents, siblings, loved ones to follow in the path of other family members? And was that ever a consideration as you started to look at medical school and things like that?
Yeah, I was encouraged not to pursue that. This is a very strange thing, but as a chemical engineer, like I said, that's what I was. There was a program to be a nuclear engineer on the submarines in the Navy, and they actually paid very well. And so that's where I went to my dad at the time and said, "Hey, this sounds like a great idea." He said, "Well, you're about 6'3", 6'4". You're not going to do well in a submarine. I don't think this is a good idea at all." And obviously that wasn't the whole reason. But then that didn't last very long, and then I ended up kind of maybe seeing the light, I guess, and went on to medical school.
Awesome. Well, that's we're blessed to have you here in Dallas because obviously what you do is very specialized. One of the questions I had on my list of questions to talk about today was, tell us a little bit more about, as a urologist, what type of conditions are you treating? Are you treating men and women? Help us unpack that a little bit.
Yeah, so I'll talk about me specifically. Otherwise, we'll get a bit too broad. But I treat men and women because what I specialize in as a part of specifically robotic surgery is a lot of the different cancers. So kidney cancer, bladder cancer. Obviously, that doesn't have a bias towards gender. Obviously, prostate cancer does, and so that affects exclusively men. And so we operate and treat both men and women in my urologic specialty. That said, we also treat a lot of benign conditions. Not to get into too much detail, but there's a lot of problems that occur with the little tube that leads down from the kidney down into the bladder. It's called the ureter. When those get strictured, that can be actually quite devastating. So we repair that in various ways, but mostly robotically. And then, there's a lot of men walking around who don't pee so well, and they have a big prostate, especially as they get older. And we help them out with that in various ways. It doesn't have to be robotics, but that's one of the best ways we found to treat it, especially as the size of the prostate gets up there.
Interesting. So, if you were to really zero in on what you enjoy the most in your specialty, like as a specific, you mentioned minimally invasive surgery, right?
Yeah.
That's still pretty broad. Is there one particular disease state or type of treatment that you specialize in, or you really enjoy pursuing treating patients with that condition?
Yeah, I mean, that's kind of an interesting question because obviously, in a way, we never want to say I enjoy treating somebody who has a bad condition, right? You prefer that condition didn't even
Right.
exist. But since they are at our doorstep and they aren't doing well, hopefully we can do a good job for them. And I think and I tell so as an associate professor, I train residents, and I tell the residents all the time, hey, the people that you're going to find the most happy, that you help the most, are these guys who walk into your clinic and they're miserable because they can't pee or they're running the bathroom, 10 times at night. They can't sleep. They can't go to a baseball game because they're looking always over their shoulder. Where's the next restroom? And then they come in and see us, and I say, hey, I know exactly what your problem is. And then we do a robotic surgery to essentially reduce the size of their prostate. And then, 4 or 5 days later, they start doing well. But then we see them, 2, 3 weeks later, 4 weeks later. And I had one guy, he was a big guy down in South Dallas. He's a pastor. And he said, Doc, I'm a man and you're a man, but if I could marry you, I sure would right now. Because he was just so happy that he was back and had his life back together, and he was just ecstatic. And he had one of the biggest prostates we've ever seen. And his quality of life just changed overnight. And so it's not cancer. I'm not saving his life, but I'm saving his quality of life. And so those guys are extremely grateful to us.
So Tyler, you're sitting over here on the sideline listening to this, right? You're not in medicine, you're in financial services.
Mm-hmm.
As a guy, what are you thinking?
Well, what I'm thinking is that I'm going to have him on speed dial about 20 years from now, hopefully not earlier. But one of the things that's really interesting is the idea of giving someone back their quality of life. And I think that's one of the really powerful things about medicine and what you guys do for folks is, and I think maybe it's sometimes we don't think about it that way. We think about, okay, we have an illness, then you're cured and you go on. But what you're really doing is giving people back the ability to do stuff that they really love to do. And I can relate to that in the work that we do for the families that we service. A lot of it's about quality of life, giving them time back, giving them confidence back, and helping them get where they want to go.
So Dr. Gahan, obviously you've really become an expert in your field, and you're seeing residents and fellows move through your program at UT Southwestern. What do you think's been the most valuable lesson that you've been able to pass on to these young folks that are entering your trade, entering your specialty? They're considering your specialty.
Yeah, I mean, it'd be interesting if you asked them that question. I wonder if it'd be the same as I'm going to give you. But what I would say is, I think it's the ability to learn and to acquire a skill set, and to constantly look at our field as such. Because I think, when I started, robotics was just kind of coming on the horizon. We'd heard about it, we weren't sure about it. By the time I was graduating, it was starting to be a thing, and now it's what we do. I mean, you don't have to do robotic surgery, but a urology practice anywhere in this country has to have somebody who specializes in it to be competitive and to offer the best care. But we don't know what the next thing is going to be. Maybe it's better robotics, maybe it's something else that we haven't even thought of yet. And so I think I'm always trying to encourage the residents to say, look, we don't know what else is out there, but have the open mind to acquire new skills, to embrace new technologies, because otherwise you're not doing your career any favors, and two, you're not necessarily doing your patients any favors if you kind of get stuck in a rut and don't acquire those techniques. Because you can look 20 years ago, I mean, we were treating these diseases much differently. And I think we would be almost appalled right now at some of the things we used to do. Not because they were wrong, it's just we didn't have the technology then. And so I think what I would hope to impart to them is, continue to learn, continue to acquire skills. Don't ever just stop and say, I've done enough, I'm old enough, I can't progress past where I am now.
I'm curious, coming out of medical school, looking back now, so you're looking in the rearview mirror thinking, man, it wasn't that long ago I was a resident. Mm-hmm. What have you learned the most? What's the biggest lesson, and how do you apply that to the teaching that you do with the residents?
Yeah, I'll tell you, I don't know if I'm going to give you the best answer, but I'll tell you one of the things that I've learned is humility. You can be one of the best surgeons in the world, and anything can go wrong at any time. And I don't want to scare anybody that way, but I think it's a very good way to look at what we do. We have to be very, very cautious. We have to be very conservative. We have to really think about what we're doing, because you can, the easiest case can all of a sudden go south real quick if you haven't prepared correctly. And so my mentor, a guy named Jeff Kadedu, basically tells us all the time, he's like, there's no such thing as free. There's nothing that's free. You have to prepare, you have to think about it, you have to be ready for the unknown, you have to be ready for A, B, and C, because most of the time A is fine, but if you haven't thought about B and C, you don't want to be thinking about it on the spot. So I think that's one thing that I've learned is no matter how good I get and no matter how good I think I am, I can always do better, and I better not think that for too long, because something will come back and show you're not.
Interesting. So, you mentioned robotics earlier, and how as you were entering residency and really getting started, that robotics was becoming a thing. What's been the most significant, noticeable impact for you as a surgeon with the introduction of robotics into urology?
Yeah, I mean, I think what it's done is it's leveled the playing field to a certain extent. What I did was a minimally invasive fellowship. Basically, we used to do minimally invasive surgery with essentially chopsticks. I mean, obviously not quite that rudimentary, but something like that. And then the robot came along. And so if you think, wow, can you tie your shoes with chopsticks? Most people would say, I couldn't even do that. Now we're taking out people's kidneys. We're taking out people's prostates. We're doing these very complicated things with chopsticks. And that was an incredible skill set that not a lot of people in the United States had. Then along came the robot, and a lot of people said, hey, I can actually do this. I can do these surgeries minimally invasively. So it leveled the playing field. Now, that doesn't mean that those really good surgeons who were good at laparoscopic surgery haven't excelled in robotics. I mean, there's still a gap. Not every surgeon can be good at robotics, and not every surgeon excels at it. But it did make it so that a lot of surgeons can start doing the same minimally invasive surgeries that prior they weren't able to do. And so I think one is it's made the group, if you look at all urologists and even general surgeons and some other subspecialties, you've made them better across the board, better surgeons. And me in particular, I've actually been able to do surgeries that I could have never done with just my hands, because one is the robot gives you 4x magnification, so it's better than my eyes. And the hands, each robotic instrument is the size of my finger, not the size of my hands. And if you can imagine trying to get into a tight space, you couldn't possibly do it now. And so we've been able to change the way we do surgery. We've actually been able to approach surgeries in a different way anatomically that we could have never done before through the conventional methods. And so we've actually almost recreated how we do the operation. When the robot came on, we were trying to do everything with the robot the way we did it with our hands. And then we realized, hey, the robot's actually better than our hands. We don't have to do it the same way. Let's think about other ways to do it. And I can go into those details more on some of the cases we've done, but that's probably getting in the weeds a bit.
Well, and that was, as I'm hearing you unpack this, right, and we're talking about the advancements in robotics and surgery, are there procedures that you now can comfortably do, or your success rate has amplified because of the introduction of using a robot? I mean, a lot of our audience, Dr. Gahan, they're not medical. They're just lay people that follow us on Facebook or LinkedIn, and maybe they have a condition, maybe they're scared, right? So share with us a little bit about the procedure specific wins or nuances that have really been enhanced, and is it enhancing success rates?
Yeah, so 100%. So I think the example that comes to my mind is prostate cancer, and this we've been taking out men's prostates who have prostate cancer for 20, 30 years. And what we can do now, well, there was a lot of problems with side effects. One of the biggest problems was urinary incontinence. So we do the surgery, and then they wouldn't have the ability to control their urine. It would just kind of leak out. They'd have to wear a diaper or a pad or something for the rest of their life. And obviously, talking about quality of life, that's pretty bad. Then there's also erectile function. That's the other big downside to prostate cancer surgery. So with the robot, and I won't take credit for it, but myself and a guy in South Korea and a guy in Italy basically started doing this thing called a Retsia-sparing prostatectomy. And basically that just means that we weren't disturbing the natural tissue planes. We were going in and going through the normal anatomy, which you could have never done with your hands. And what that led to was that because we didn't disrupt the anatomy to the extent that we used to, when we take the catheter out, in a high percentage of patients, those guys are continent from day one. And that was unheard of 10 years ago. That was just not even a thing. That wasn't even almost possible. And now it's not, I wouldn't say common, but it is a reality that can happen. And so you're going from a guy who was going to leak urine for the rest of his life to a guy who never leaked urine for one day in his life. I mean, that's a big difference. And that's not, and I'll tell you, you couldn't do it the conventional way. Now, I'm not going to sit here and promise that I can do that for every patient because there's a lot of variables that come into play there. But 10 years ago, if I told somebody, hey, I can do an operation, I'll pull the catheter out, and you're never going to have a drop of urine spill that you didn't want to in your life, people would say, you're crazy. But we're there.
That's really cool. So, being able to improve the success rate of not creating incontinence is one thing, but when I think cancer surgery, whether it's prostate or kidney or whatnot, I think about good clean margins. I think about being able to spare as much healthy tissue as possible. How has a robot enhanced that portion of the procedure, and talk a little bit about that with us?
Yeah, so I think that's where the subtleties of surgery and of robotic surgery in particular come into play, because we were always pretty good about getting the cancer out. It just meant that maybe you had an incision that went from your sternum down to your pubic bone, but you still got the cancer out. It's just that's what it cost you, or it cost you your continence. Or in the case of kidney surgery, you had a big surgery that with a big surgical incision that was extremely painful. So it's allowed us to do the same kind of cancer operations, but without causing the impact into your life. So, for example, a kidney surgery where we took out part of the kidney because it had cancer in it, we left the other kidney or the rest of the kidney intact. That used to be 5-6 days in the hospital. Now it's 1 day in the hospital, and you could argue a lot of those guys are probably ready to go home that night in terms of their pain. So we've really moved that needle that way. Now, are those patients living longer because of this? No, not really, because again, we always focused on doing it from an oncologic perspective, what was safe. We never compromise, or we never want to compromise oncologic outcomes for a patient, comfort. We still make sure that cancer is always out. But now we've been able to do that safely, routinely, and with the patients having much, much better pain control, quality of life, and those kind of things.
Walk me through the difference now versus traditional surgery when you were coming out as a resident. How do you prepare for one of these surgeries, and what does it look like? Are you sitting there with joysticks and?
Yeah. So that's an interesting question. So the robot has gone through some iterations, but it's not vastly different. It's like, so let me use a couple examples. One is, I always get asked, is the robot doing the surgery? And I say, no, the robot's not doing the surgery. I'm still doing the surgery. I think probably the best example would just be to go to YouTube and Google, robotic surgery for somebody to see what it looks like. It's kind of hard to describe. But what I tell everybody is, look, it's like if you're driving down the road in your, Chevy Bolt or something, but and that's one, that's what you want to drive. But if you want, what I'm driving is a NASCAR race car, and so, but you still need a driver to go around the race car track. I mean, you can go around it, but without that expertise, that driver, it's not going to do a whole lot. So the misconception is we dock the robot and it just kind of does it. No, we're controlling every step of it. It basically, what it does is it recreates your wristed movement, and that's kind of the magic of the robot now. Is so whatever you can do with your wrist, it can recreate those movements. And before, when we were using the laparoscopic instruments, it was literally just these kind of movements, whatever you can do with a straight stick. And so now we have these wristed movements. And we can get into tighter spaces. We can, throw our sutures in a better angle. We can cut things that we could never cut before. And then the robot also magnifies everything by 4x. So it's better than my eyes. And so all of those things have really helped us offer a better surgery to the patients. But yeah, it is us sitting down just like at a station here, and the robot would be over there as I do the surgery. We're still in the same room, but and we're connected, by fiber optic cables. But I'm not actually at the patient's bedside.
So interesting.
Dr. Gahan, I think about the inclusion of robotics, and I've heard horror stories of providers, support staff saying, "Hey, this surgery laparoscopically used to take 45 minutes. Now it takes 3 hours."
Mm-hmm.
And we know there's clear evidence that after a certain point in time, the longer the patient's under anesthesia, the higher the risk for complications and infection rates and things like that. What's been the impact of adding robotics to your toolkit when it comes to length of case, when it comes to infection rates, when it comes to things like that?
Yeah, I mean, for me, it hasn't added any time. But again, you're talking to somebody who kind of specializes in it, who's what would be considered a very high volume surgeon, doing, I don't know how many, probably well over 150 cases a year, versus somebody who maybe dabbles in it, does 10 cases a year. So for me, yes, it actually improves my speed. I'm faster with the robot. The infection rate is probably about the same. But going back to my analogy, it's like driving a NASCAR race car around a racetrack. Like, you put me in a NASCAR, and all I'm going to go do is cause an accident. So if you don't understand the technology, if you don't know how to use it properly, yeah, it's not right for you. You have to be trained. You have to go through the training. You have to have the experience to be able to use the technology properly. It's not plug and play. It's not like you walk up there and say, "Now I'm a surgeon." No, that's why we went through 6 years of training to do this.
Right. What percentage of the cases that you perform use the robot now?
I mean, of the cancer cases, a very high percentage. I mean, 80-90%. Now we've gotten to the point where even for the more advanced cancer cases, where it used to be the dogma was, oh, you still do it the conventional way. You still have to get your hands in there and feel it and touch it. And now we say, actually, no, we prefer robotics even in those cases. We're just so much better because of the technology. One of the things that always was listed as a kind of deficit in robotics is you can't feel how hard something is because there's no tactile feedback. So if I hit something, I can't tell it's hard. But what actually happens is over time, you can see how the instruments and the tissues respond, and you actually get an idea of how hard something is just by the way it deforms when you touch it. And so these more advanced cancer cases, it was always thought, oh, you have to be able to touch it, you have to be able to feel it. Well, now we've gotten so good at it, I don't have to touch or feel anything. I can just see it, see how it reacts, and I'll tell you if that's a hard thing, a cancerous thing, or if it's a soft, benign thing, and if that's the right tissue, that we want to be dissecting through or not. So we've actually moved towards, even the more advanced cancers as using this as our technique.
Interesting. So, I have a couple of family members that are love them to death, but they're just, the lens that they see through is very narrow, right? It doesn't look very far into the future. And when they hear the word robotic surgery, I start talking about our staffing company working alongside surgeons in robotic procedures, their eyes get as big as saucers. And they're like, oh, never. I'm never going to have a robot touch me. And talk to us about patient engagement and patient feedback and how patients view robotics when you start talking about that being a possibility for their procedure.
Yeah, I mean, now it's, I would say that was a conversation I had up to maybe a few years ago. It's definitely dropped off. I'll still get the occasional patient who will say, who's concerned about the robotic approach and those kind of things, and you have to talk them through it. I used to give a talk where I had all of the lawsuits brought against Intuitive, the robot maker, and I'd say, this is what patients think. They see this, and these are all these, disastrous lawsuits. But then you start to explain it to them. You say, look, it just makes my hands smaller. It makes my instruments more accurate. It makes my vision better. This is, again, these are all the things that we use every day. Nobody would think about, well, I have to drive or I'm a 30-minute commute to work. I'm just going to use my bike because I don't like the technology of a car. That's crazy. So you're always, we're constantly, the technology around us is constantly advancing. And then at a certain point, it becomes commonplace. And I think we're starting to move into that realm where robotics is just a commonplace. It's not like a car, but it's being adapted to the point where if you went and said, I don't want this surgery done robotically, you might not be able to find a surgeon to do it at all then. Because, for example, a prostatectomy, there's probably not a lot of guys out there, which is the removal of the prostate. There's not a lot of guys out there, or guys or girls, doing prostate surgery without the robot. It's just been shown to be inferior.
Do you think there's such a thing as overuse or over application of robotics and surgery at this point?
Yeah, I think they're probably. That's a load. It's a little bit of a. So yes, the answer is probably yes in some specific areas. But one of the things that I've found is that we'll apply it to a new surgery. For example, I was talking to you about this scenario where these guys had these big prostates and they came in. Well, the conventional way of treating this was an open approach where we'd make a big incision and put our finger in and do the dissection and all that. And those guys had about 20%. 20% of them had to have a transfusion after surgery. The hospital stay was 4 to 5 days. It was a mess. We applied the robotics approach to this surgery, and I got a lot of pushback from it. They said, "Well, it's just costing too much. You don't really need it. That was a good surgery before. Yeah, you had some bleeding issues, but." So we actually looked at this, and I studied our own data, and I said, "Look, our transfusion rate is now probably 1%, and it's falling. That's when we started. Now it's even lower." The patients were starting to make this an outpatient procedure even. So we took it from 5 days to almost outpatient. We took it from 20% transfusion rate to probably going to get less than 1% if we look back at our data at this point.
Wow.
That's just one example. But the initial pushback was, you don't need to be using this tool. It's too expensive. Why are you using it? You don't need it for this. And so I think there is that idea from especially administration who says, wait, this is an expensive tool. Do I really need you to be using it all the time? And my answer is that, well, I'm going to use it when I think it's best for the patient. And eventually you're going to show them that you're right. Because, we're not going to use something that's not good for the patient. We're just not. Our interests aren't there. Our interests are to provide the best care.
That's the age-old bean counter versus physician battle.
Right.
That's that war that's been waged in healthcare for decades.
Right.
And it seems to be worse now than ever. So interesting to hear you really focus in on, it's not based on your preference, it's based on application to the particular patient and whether or not it's going to make the procedure more effective or more successful is what I'm hearing you say.
That's just the principle of life. You do what's in people's best interest. Whether it's, that's what you should do. If you're a professional, it doesn't matter what industry you're in. You should do what's in their best interest. But
especially in our industry, you could argue other industries, maybe that's, but in healthcare, you got to think that that's where our focus should be. And the thing is good patient care is good business. If you there's a reason, and I'm not trying to get on a high horse here, but there's a reason I see people from Amarillo and El Paso and all these other places. It's because they hear about UT Southwestern. They don't hear about me necessarily. They hear about UT Southwestern because we provide an excellent care, and they're coming to see us. And it's because we provide an excellent service. And so that's good business too. And so when we get too much pushback, sometimes I'll just say, look, this is the best thing for it. Yeah, maybe in the short run you're not making a huge profit, and I have no idea because I'm not on that side of it at all. But in the long run, if we do what's best for the patient, it's going to be the right thing. So.
Pretty interesting. So let's pivot for a moment and let's talk about the COVID effect on your practice. Share with us a little bit about kind of what you guys have been through in the past year, what you've seen with patient volumes, with referrals, with the types of patients that are now crossing your doorstep post-COVID. Interesting to hear about that.
Yeah, I think this is going to be very interesting when we finally have enough data to actually look back and actually have the statistics for it. Right now, it's more anecdotal, and we all have our biases, right? And so, I have this, in my head how it is, and so I don't know if it's real, but I'll tell you, especially at the VA. I've seen it where patients said, well, I don't want to go to the hospital because of COVID, or they had to go get a COVID test to have the surgery, and they didn't want to go get the test, so it was canceled. For whatever reason, the COVID caused the surgery or the diagnosis to be delayed, and we're starting to see those patients come back around, or we did, and for example. We do a handful of bladder cancer or bladder removals, 1 or 2 a month at the VA. And then, when COVID kind of subsided, all of a sudden we were doing 3 or 4 of these a month. And you got to think, where do these all come from? And it's probably partly the COVID effect. We saw, I was doing, more advanced kidney cancers than I would typically see. And this all happened in the last probably 3 months or so. And I think what happened was his patients finally started to come to the doctor for those little things, those little subtle clues that normally they would have gone to see the physician for, and they kind of put it off. Understandably so. We didn't know what was happening. COVID was scary. There was no vaccine for a while. And so I think there was a lot of, especially among the veteran population, there's a lot of older guys, a lot of them are sick, and they were avoiding the hospital. That makes sense. But now I think we're seeing that lack of it's not access, but that lack of involvement in the healthcare system may be coming back to kind of haunt us a little bit. But again, that's just my anecdotal experience. I'm sure this is going to be looked at, and I'm sure we're going to see some papers written about it, and we'll see if I'm right. But I've definitely seen it, and I think I'm not the only one.
So, you just said something that brings me to another question, which is how much research are you actively doing today versus seeing patients? Because we hear stories of physicians in academia that see very few, and this has actually been a hot topic with all this COVID stuff, but physicians that work in academia, that they actually see very few patients, and all they do is research and write papers.
Yeah.
And then they go speak. Talk to us about that mix of your professional life. What does that look like?
I'm probably 95% seeing patients and operating and 5% writing papers. So actually for us, we're just incredibly busy. There's just a high demand for our skills in urology. And I think, again, UT Southwestern is what we call a tertiary care center. So we're getting patients referred from all over DFW, surrounding areas, East Texas, North Texas, West Texas, and so we're so we don't have the kind of the luxury of sitting back, kicking our heels up, and saying I'm going to do some research papers. That does exist, but it's pretty rare these days in terms of urologists. I think we're just in such high demand. The other thing, though, is when we offer fellowships and the resident training, part of their experience is to kind of wade into the research realm, and so we're kind of supervising that. We're giving them the 30,000-foot view, but we have other people who are kind of helping to do answering those questions, just like you had. What has been the COVID effect? Well, hey, that's a great thing for maybe one of our fellows to look at, because they work with us, but they also have a little more time set aside for research. In general, I would say the vast majority of urologists you're going to see, even those in academia, are working pretty hard in the clinical sector, and the academic part is pretty. It's there, and that's why we're in academics, but it's not the majority of the time we spend.
Gotcha. So, is there anything that you guys are studying or looking at right now that you can share with our audience that may be of interest, or how does that work?
I mean, So I think one of the most interesting projects that we have right now is a partnership with SMU. And it's with the computer science department, and we're looking at there's a thing called machine learning, which is just a subset of AI, artificial intelligence, and we're looking to see if we can develop tools, what we call algorithms or models, to actually look at a surgeon and show and predict how good of a surgeon he or she is, just from a video feed or from information that's given to the computer. And the idea would be, one day it would be to help with training, so we can have the residents kind of fed through the system. But then maybe one day in the future, maybe distant future, we could start saying, hey, now we're going to have some metrics that people have to live up to be a robotic surgeon. You can't just set up shop and say, hey, I'm a robotic surgeon. You have to submit a case log, and then the computer can review it. And the reason that's interesting is because if you sit down and try to review this manually, it's a 2-hour surgery. That's one surgery. Now think about the thousands of surgeons across the country, and you want to look at 10 different surgeries. I mean, now you're talking tens of thousands of hours of man hours. And so if you can automate this, I think there might be something interesting there. But this is, very, very, new and in the works. But it is, I think it is the future. I mean, everybody's heard of AI and how it's changing everything. And so I think we're just getting to, we're just breaking into that field, and it's gonna explode in the probably next 2 or 3 years.
Super interesting. So, final thoughts of what you see. Take a look out on the horizon for the next 5 years in the area of medicine that you're in urology. Is there anything that makes you super excited that you go, man, this could really change how we treat patients? It could change our success rate, or is it just incremental improvements in what you're doing now?
Yeah, I mean, it's kind of, so if you're asking surgery, I think there's every once in a while there'll be a quantum shift, but generally speaking, it's incremental. It's somebody like me sitting down and saying, hey, here's a better way to do this particular operation, kind of figuring it out. Now, I'm not the only one who's done it. Somebody else figured it out a different way somewhere else. But it's incremental. But that's also somewhat dependent on the technology. I know that we wanted to focus on robotics here, but to answer your question truthfully, I think the most exciting thing, especially in the cancer world, is a lot of the immunotherapies that we're seeing coming on the scene. And that has been a complete game changer in treating diseases that before it was a death sentence. And now we're saying, hey, we can give you some time. We don't know how much, but we can give you time. And that was not the case 3, 4, 5 years ago, maybe a little longer than that. But and again, because of the technology, just like you saw with COVID, how they developed the vaccine. I mean, within months they actually had it. It's because of the technology, because of the AI, we're starting to see these drug companies that are quickly figuring out how to design these new drugs. And that's, I think, where we're really seeing the booming effect, and we're really moving the needle forward. What I would say, though, that's very interesting is now how that combines with surgery, because a lot of these drugs we're starting to look at and say, okay, now if we give these up front, now can we come back and do surgery behind them to really, kind of consolidate the treatment? And so it's what's starting to happen, I think, is we're going to start to see it's not just a drug or a surgery or a radiation. It's going to be maybe all three of those things coming together to really offer the best chance for a cure. And I think, where we were 10 years ago is very different than where we are now for bladder cancer, kidney cancer, and even prostate cancer. I mean, what I learned in medical school or in residency was easy because there was so few drugs that I could use. I didn't have to remember that much. And now I can't even keep track because the studies are coming out so quickly that there's another new drug all of a sudden FDA approved because it was shown in a randomized trial that it does great things. And so I think that's what's exciting is the massive increase in drug development.
Wow, Tyler, I'm going to guess you're kind of sitting back, just soaking this all in, going, this is crazy. This is incredible stuff. I mean, thoughts from you as we start to wrap up.
Yeah, there's a reason why insurance companies have taken mortuary charts out another 10 to 15 years in life expectancy. I mean, it's the technology and guys like this that are this smart, this bright, and that really do want to be a part of not just patient care, but actually the development of new techniques and to be on the cutting edge of that. I mean, it's fascinating. This might be of all the podcasts the most fascinating to me so far. Just it's amazing. It really is.
Yeah, it's hard to wrap my mind around some of the things he said today about the degree of just improvement or acuity that can now be treated based on the technology that's been put in place, which is super exciting, right? It gives me great confidence that if I do get sick, there's a great chance that either it's going to be really beaten down to the point where I can have a good quality of life for a longer period of time, or it can just flat be cured. So, Hey, Dr. Gahan, would love to hear final thoughts from you. We've talked about a bunch of things here today. If you're talking to our audience and there's some people on here that are going to listen to this and they're going to be sitting on the fence. They've been sitting on the fence for a while about coming in to see their primary care doctor, to seek treatment, to seek an opinion. What would you say to those people?
Yeah, I think that's a really good segue into what I'm going to say next. Is that look, our guidelines now, especially with prostate cancer, and I'll just use this as an example, are what's called shared decision making. So I'm not supposed to talk at you. I'm not supposed to tell you what to do. I'm supposed to sit down with you and say, here are your options. Here's here's 3 things that we can do, 4 things we can do. I'll tell you what I think I might do, but I'm coming at it from my own biases. You have to give me your expectations and limitations to make a decision. And I think so to that person who's on the fence, going back to your question, I think part of it is sometimes they don't want to come in and be told what they're going to do. And I think I would say if you're going and seeing a physician who's talking to you that way, I mean, there's things like, I would recommend you start this blood pressure medication, whatever. But in those big decisions, it always should be a shared decision-making process. It should never be, here's what you're going to do. And if you don't do that, you're stupid. Mm-hmm. You're doing the wrong thing. Oh, well, we'll see you later because you're not following my recommendations. And so I would say that if you're on the fence, one, yes, come on in and get something checked out. But you're not committing yourself to anything. You're committing yourself to a discussion. And then depending on how the discussion goes, decide if that's the guy or girl that you want to see, Or maybe you branch out and find somebody who you really actually want to have a discussion with, because it always should be a discussion. Your health should be a discussion. It shouldn't be me telling you how you should live. And even in cancer, which you would think that, oh, that's pretty black and white. It is not at all black and white. Patients have very different desires, and you have to feel those out. And so unfortunately, in our world, maybe not unfortunately, but that's time consuming. And so you need to sit down and hear the patient out, and then figure out, okay, this is why they think that. This is why they're coming. Going back to your family who had the eyes wide open about the robotic surgery, you have to figure out why they're coming from that perspective. And usually, once you figure that out, you can kind of say, okay, well, here, let me allay those fears. It's not the robot doing it; it's me. It's just a better me doing it. And so I think that's where I would say is for all those patients on the fence, look, don't be afraid of healthcare. It is overwhelming. It is scary. And if you're not happy with the person you're talking to, find somebody you're happy with, because there's a lot of us out there. And maybe I'm not the right guy for you, but maybe one of my partners is. And seek those people out, because that's you're right. That's what you're entitled to. You should have a physician who's on your side, making those decisions with you, not for you.
Dr. Gahan, can't thank you enough for making time to come join us today. I think this has been an awesome discussion about a lot of topics related to various treatments in the field of urology and what's going on with robotics and all the advancements. It should make people hopeful that if they do have a condition that needs to be treated, they shouldn't hesitate.
Absolutely.
And Tyler, I appreciate you holding down the fort there in Dallas while I'm away.
Of course.
This is why we love to do this, because man, this is as much about talking to our community, our friends, our family, the average layperson, as it is to speaking to our colleagues in the medical community. And I think there's much that can be learned by these types of topics and these discussions. So, for today, we're going to wrap up. Dr. Gahan, again, thanks for making the trek up north after a busy day, and we look forward to talking to you again soon.
Sure, loved it. It's great.
Thanks, CJ.
All right, everybody. Have a blessed day.
All right,
We'll talk to you soon. See you next week for episode 10.